So I know that I already gave you guys the PowerPoint with the notes. I'm hoping that that was helpful for you, but so I know some people are audio learners or auditory learners, I should say. So I would like to go through this PowerPoint for those of you who would prefer to listen to it, since we didn't get to really do that. And this is a very long presentation, so I'll probably split it up into a couple. That way they're a little bit easier to kind of compress and get posted for you guys. So starting out, Chapter 32, Children and Adolescents. So this chapter examines various disorders in which the symptoms usually first become evident during infancy, childhood, or adolescence. It's important to know all nurses working with children or adolescents should be knowledgeable about the normal stages of growth and development. Behavioral responses are individual and idiosyncratic, but they are indeed human responses. Uh, Guidelines for making a determination if a behavior constitutes emotional problems should consider the appropriateness of the behavior regarding age and cultural norms and whether the behavior interferes with adaptive functioning. So, this chapter focuses on the nursing process and the care of clients with intellectual disability. We'll cover autism spectrum disorder, ADHD, conduct disorder, oppositional defiant disorder, Tourette's disorder, and separation anxiety disorder. So first, starting out, intellectual developmental disorder. In DSM-5, it defines intellectual disability, which they once called mental retardation. We no longer use that term anymore, but it is defined as a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. The incident rate in the general population is about 1%, and the onset occurs during the developmental period. The level of severity can be mild, moderate, severe, or profound. So there are four levels of severity, and is based on adaptive functioning within 3 domains. General intellectual functioning is measured by both clinical assessment and a person's performance and IQ tests. Adaptive functioning refers to the person's ability to adapt to requirements of activities or daily living in the expectations of his or her age and cultural group. Genetic factors. So the etiology of intellectual disability may be primarily biological, primarily psychosocial, a combination of both, or in some instances unknown. Um, so potential predisposing factors to intellectual and developmental disabilities. Genetic factors are implicated as a cause of intellectual disability in approximately 5% of the cases. These factors include inborn errors of metabolism, such as Tay-Sachs disease, phenylketonuria, and hypoglycemia, which is those abnormally high levels of glycine. Also included are chromosomal disorders such as Down syndrome and Klinefelter syndrome, and single gene abnormalities such as Fragile X syndrome, tuberous sclerosis, and neurofibromatosis. Conditions that result in the early alterations in embryonic development account for approximately 30% of intellectual disability cases. Damage may occur in response to toxicity associated with maternal ingestion of alcohol or other drugs. Fetal alcohol syndrome is an example of this disorder and has been identified as one of the leading preventable causes of intellectual disability. Maternal illnesses and infections during complications of pregnancy can also result in congenital intellectual disability as well. Um, Approximately 10% of cases of intellectual disability are the result of circumstances that occur during pregnancy or during the birth process. Examples of the latter include trauma to the head incurred during the process of birth, placenta previa or premature separation of the placenta, and prolapse of the umbilical cord. Um, General medical conditions acquired in infancy or childhood. So this accounts for approximately 5% of cases, and this includes infections, poisonings, physical traumas. Sociocultural and other medical disorders. So between 15 and 20% of cases of intellectual disability may be attributed to deprivation of nurturance and social stimulation, and to impoverished environments associated with poor prenatal and perinatal care and inadequate nutrition. Additionally, other mental disorders such as autism spectrum disorder can result in intellectual disability. Looking at assessment, the degree of severity of intellectual disability, again, may be measured by the client's IQ level. And I talked about those 4 levels that have been delineated. Um, the levels are differentiated between the ability of the child to perform self-care, cognitive and educational abilities, social and communication capabilities, and psychomotor capabilities. Looking at nursing diagnoses, so we are able to we assess that patient or that client, and we take that information, we put it into the client database, and then we can choose an appropriate nursing diagnosis, and some of those are listed here on this slide. And there are additional ones here as well. Now when we look at goals, outcomes, so we know that goals we need to have both short and long-term goals. Timelines, are individually determined. And these are the things on this slide that we would like to see as an outcome: that they have experienced no physical harm, self-care needs are fulfilled, they are able to interact with others appropriately, are they able to maintain anxiety at a manageable level, accept redirection, demonstrate adaptive coping skills, so all very important. Nursing interventions with ADHD. We need to be ensuring the child remains free from injury, maximizing the child's ability to perform that self-care, establish communication patterns, and behavior modification procedures with rewards and aversive reinforcement. Plan of care is directed toward the individual client with participation of primary caregivers. It is essential that family members or primary caregivers participate in the ongoing care of the child with intellectual disability. They need to receive information regarding the scope of the condition, realistic expectations of the child's potential, methods for modifying behavior as required, and community resources from which they may seek assistance and support. Evaluation, of course, we look at the interventions we implemented. Were they effective? Has that client remained free from injury? Have their self-care needs been met? They've been able to communicate their needs and be understood. Have they learned to interact appropriately, accept constructive feedback, and discontinued any inappropriate behavior? Are they able to maintain anxiety at a manageable level again and learn those new coping skills through behavior modification? For primary caregivers, have they demonstrated understanding of realistic expectations of that child's behavior and methods for attempting to modify unacceptable behaviors? Have they demonstrated awareness of various resources from which they can seek assistance and support within the community? To autism spectrum disorder. Um, So the DSM-4, the category of ASDs encompassed a broad spectrum of diagnoses that included autistic disorder, Rett's disorder, childhood disintegrative disorder, pervasive developmental disorder, not otherwise specified, and Asperger's disorder. The DSM-5 groups these disorders into a single diagnostic category, and that is autism spectrum disorder. The diagnosis is adapted to each individual by clinical specifiers, so level of severity again, and verbal abilities and associated features, any known genetic disorders such as Rett's disorder and Fragile X syndrome, epilepsy, intellectual disability. Autism spectrum disorder includes a wide range of symptoms and levels of severity that impact thinking, feeling, communication, and social relationships. Behavior is often limited and repetitive, but each child is likely to have a unique pattern of behavior and level of severity from low to high functioning. Looking at neurological implications, imaging studies have revealed several alterations in major brain structures of individuals with ASD. Total brain volume, the size of the amygdala, and the size of the striatum are enlarged in very young children, and there's evidence of a decrease in size over time. Looking at genetics, research has revealed strong evidence that genetic factors play a significant role in the etiology of ASD. About 15% of ASD cases are related to a known genetic mutation. In most cases, its expression is related to multiple genes. Genetic studies have identified genes are linked to both autism and schizophrenia, which suggests that the two conditions are related, but the same genetic variations also appear to confer risk for other neurodevelopmental disorders as well. Looking at prenatal and perinatal influences, some of the prenatal risk factors that have been associated with the development of ASD include advanced parental age, fetal exposure to valproate, gestational diabetes, and gestational bleeding. Prenatal, looking at assessment, it's important to understand the symptoms of ASD occur along a spectrum and varying levels of functionality. Some individuals who meet criteria for ASD may be highly functional and highly intelligent in spite of communication impairments and repetitive or restrictive behaviors. Impairment in social interaction. Children with ASD have difficulty forming interpersonal relationships with others. They show little interest in people and often do not respond to others' attempts at interaction. As infants, they may have an aversion to affection and physical contact. As toddlers, the attachment to a significant adult may be either absent or manifested as exaggerated adherence behaviors. In childhood, there's a lack of spontaneity manifested in less cooperative play, less imaginative play, and less friendships. Impairment in communication and imaginative activity, both verbal and nonverbal skills are affected. In more severe levels of ASD, language may be totally absent or characterized by immature structure or idiosyncratic utterances, whose meaning is clear only to those who are familiar with the child's past experiences. Nonverbal communication, such as facial expression or gestures, may be absent or socially inappropriate. Looking at nursing diagnoses, so again, we take the information that we've collected during our assessment, implement that or input that into our client database, and then choose appropriate nursing interventions. And these would be some appropriate nursing interventions for ASD. And looking at outcome criteria identification, we have goals that are both short and long term. Again, timelines are individually determined, but these are some of the things that we would want to see as outcomes for this individual. In implementation, nursing interventions so the goals for treatment of a child with ADSD should focus on preventing self-harm, helping the client initiate social interaction, establishing a means of communicating needs, and helping the client to develop ego identity. Interventions should include working with the child on a one-to-one basis, giving positive reinforcement, and assisting the child in recognizing separateness. Evaluation, again, we look at those interventions we implemented and the efficacy of them. Have they been able to establish trust with at least one caregiver? They remain free from mutilated behaviors or other forms of self-harm. They attempted to interact with others. Have they received positive reinforcement for those efforts? Have they improved in ability to maintain eye contact? Have they established a means of communicating needs and desires to others? Had all self-care needs been met? Have they demonstrated an awareness of self as separate from others? Do they accept touch from others? And have they been appropriate in touching others? Pharmacologically, interventions there are directed toward relief of targeted irritability symptoms such as aggression, hyperactivity, self-harm, impulsivity, and temper tantrums. So there's really no medications that treat the core symptoms of ASD, but there have been two that have been okayed by the US or by the FDA. One of them being risperidone or Risperdal, and that is used in children and adolescents aged 5 to 16. The other is a Riprazole, and that is Abilify, and that is used in children and adults 6 to 17. Looking at ADHD, we look at the hyperactivity, which is that excessive psychomotor activity that may be purposeful or aimless, accompanied by physical movements and verbal utterances that are usually more rapid than normal. These children are highly distractible and unable to contain stimuli. That motor activity is excessive, movements are random and impulsive. Onset of the disorder is difficult to diagnose in children younger than 4 years old because their characteristic behavior is much more variable than that of older children. Frequently, the disorder is not really recognized until the child enters school. It is estimated that 50 to 70% of cases, or in 50 to 70% of cases, ADHD persists into young adulthood. Like other psychiatric disorders that are typically episodic, the adult with ADHD has symptoms that are chronic and unrelenting. Oops. And that impulsiveness is the trait of acting without reflection and without thought of the consequences of the behavior. So they feel an abrupt inclination to act and almost the inability to resist acting on certain behavioral urges. Essential behavior pattern is inattention and or hyperactivity, impulsivity. So it is more common in boys than in girls. Prevalence among school-age children, 10.4%. Again, 50 to 70% persistent to young adulthood, and 25% will meet criteria for antisocial personality disorder as adults. It is so in making the diagnosis of ADHD, the DSM-5 criteria are further specified according to current clinical presentation. These subtypes include combined presentation, so that combined type, predominantly inattentive presentation or predominantly hyperactive impulsive presentation. Looking at biological influences, genetics, so several studies have revealed supportive evidence of genetic influences in the etiology of ADHD. Twin and family studies showed that the heritability for ADHD exceeds 75%. Adoption studies reveals that biological parents of children with ADHD have more psychopathology than the adoptive parents. Biochemical theory hypotheses about the impact of neurotransmitters have been based on the benefits associated with taking stimulant medications, which are thought to increase the availability of dopamine. Researchers have found a significant risk of new onset psychosis in ADHD clients taking amphetamines, almost double the risk than for those taking methylphenidate. Looking at anatomical influences, some studies have implicated alterations in specific areas of the brain in individuals with ADHD. Some of those studies show decreased volume and activity in the prefrontal cortex, anterior cingulated globus pallidus, caudate, thalamus, and cerebellum. Several alterations occur in neural connectivity. Looking at environmental influences, so that kind of brings me, early risk factors for the development. Just kind of thinking about environmental factors of ADHD include prenatal tobacco exposure, premature birth, and low birth weight. Intrauterine exposure to toxic substances, including alcohol and lead, can also produce effects on behavior. Other perinatal and postnatal influences that may contribute to ADHD are that low birth weight, trauma, early infancy infections, or other insults to the brain during this period. Studies continue to provide evidence of the adverse effects of elevated body levels of lead on cognitive and behavioral development. The water crisis that began in 2014 in Flint, Michigan, I'm sure most of you guys have heard of, highlighted concerns about lead exposure that continues to be a public health concern in thousands of cities in the United States. Diet factors, the possible link between food dyes and additives such as artificial flavorings and preservatives, and sugar was introduced in the mid-1970s. Studies on all of these possibilities have failed to confirm a clear link to ADHD. However, a recent study did. Looking at assessment, a major portion of the hyperactive child's problems relate to difficulties in performing age-appropriate tasks. Hyperactive children are highly distractible, have extremely limited attention spans. They often shift from one completed activity or task to another. They demonstrate behaviors that inhibit acceptable social interaction. They are disruptive and intrusive in group endeavors. They have difficulty complying with social norms. Some children with ADHD are aggressive or oppositional. Children with ADHD have boundless energy, exhibiting excessive levels of activity, restlessness, and fidgeting. They experience a greater average number of accidents, from minor mishaps to more serious incidents that may lead to physical injury or the destruction of property. Common comorbid psychiatric disorders that are prevalent with ADHD. The prevalence of comorbid psychiatric disorders is common, with up to 30% demonstrating comorbid depression and 20% demonstrating comorbid anxiety. The APA in 2013 reports that in children with ADHD you have both symptoms of inattention and hyperactivity and impulsivity. Oppositional defiant disorder co-occurs about 50% of the time. Comorbidities include conduct disorder, specific learning disorder, anxiety, depression, and intermittent explosive disorder. While bipolar mania and ADHD share many core features, children with bipolar 1 disorder exhibit symptoms that wax and wane. Children with ADHD have more persistent continuous symptoms. Bipolar disorder and ADHD can coexist, though. ADHD is associated with frontal lobe abnormalities, which supports the finding that 89.4% of children with frontal lobe epilepsy also have comorbid ADHD. Again, we take our assessment data and um, put that into that client database and choose appropriate nursing diagnoses. And these would be some of the nursing diagnoses that you would see for ADHD, or appropriate ones. At outcome criteria, again, what do we want to see? We want to set both short and long-term goals. Again, timelines are individually determined, but these would be some of the things that we would want to see as outcomes. Nursing interventions with a child with ADHD. So goals for treatment of a child with ADHD should focus on preventing injury, observing limits on intrusive behavior, demonstrating increased feelings of self-worth, and completing assigned tasks independently. Interventions should include ensuring the client has a safe environment, developing a trusting relationship, offering recognition of successful endeavors, and establishing goals that allow the client to complete tasks. So question number 1, an adolescent diagnosed with ADHD is having difficulty maintaining concentration in the in-client milieu. Which nursing intervention would help improve the client's task force? So if you want, go ahead and pause this and decide which one you think it would be. Correct answer is C. A client with a short attention span can be overwhelmed with large tasks. So rewards for task completion are more successful than punishments for task completion failure. Positive reinforcements increase self-esteem and provide incentives for future positive behaviors. Again, looking at evaluation, have our interventions been effective? Have they remained free from injury? They have they been able to establish trusting relationships with the primary caregiver? Have they responded to limits set on unacceptable behaviors? Have they been able to interact appropriately with others, verbalize positive statements about self, complete tasks independently or with minimal assistance, or been able to apply self-control to decrease motor activity? Pharmacological intervention, particularly CNS stimulants, are considered the first line of treatment for ADHD. The mechanism of action is unclear, but because these drugs are believed to elevate dopamine and norepinephrine levels, it has been hypothesized that their effectiveness in response to neurotransmitter dysregulation, or is in response to neurotransmitter dysregulation. They have generally mild side effects, but are contraindicated in anyone with cardiac problems or risk for cardiac problems. There is an increased risk for new onset psychosis with amphetamine stimulants, which release about 4 times as much dopamine as methylphenidate. One study explored whether use of stimulants had an impact on reducing injuries and hospital admissions for children with ADHD. They found that children treated with ADHD drugs, mostly stimulants, had a twofold higher risk of injury related hospital admissions than those not treated with ADHD drugs. They also found that children who were using ADHD drugs and psychotropic drugs, such as antipsychotics and benzodiazepines, had a 5-fold increase in risk for injuries and hospital admissions compared to those that were on ADHD medication alone. Moving on to Tourette's disorder. So this is characterized by the presence of multiple motor tics and one or more vocal tics, which may appear simultaneously or at different periods during the illness. This may cause distress or interfere with social, occupational, or other important areas of functioning. The age at onset of Tourette's disorder can be as early as 2 years, but the disorder occurs most commonly during childhood, so around the age of 6 or 7. Prevalence of the disorder is estimated to be between 3 and 8 per 1,000 in school-age children. The lifetime prevalence is estimated to be 1%. Exposing factors, so again, those biological factors, abnormalities in levels of dopamine, choline, N-acetyl aspartate, creatine, myoinositol, I don't even think I pronounced that right, I apologize, and norepinephrine have all been demonstrated in neuroimaging studies, and the effectiveness of antipsychotic medication and suppressing tics also supports neurotransmitter involvement in Tourette's disorder. So when we look at various genetic studies, including twin studies and adoption studies, all support a genetic basis for Tourette's disorder. Recent studies suggest that the pattern of inheritance is complex, probably involving several genes influenced by environmental factors. In addition, genetic studies suggest that ADHD and obsessive compulsive disorder are genetically related to Tourette's disorder. As many as 50% of clients with Tourette's disorder also have ADHD, and up to 40% have OCD. Looking at and I kind of jumped around there a little bit. I apologize about that. Structural factors, neuroimaging brain studies Looking at predisposing factors, again, some studies have shown that environmental influence, such as maternal alcohol use during pregnancy, low birth weight, complications during childbirth, and infection may be associated with the development of Tourette's disorder. But again, further research is needed. Looking at assessment, the motor tics of Tourette's disorder may involve the head, torso, and upper and lower limbs. Initial symptoms may begin with a single motor tic, most commonly eye blinking, or with multiple symptoms. Initially, tics tend to occur in the face and neck and progress downward to the torso and lower limbs over time. Simple motor tics include movements such as eye blinking, neck jerking, shoulder shrugging, and facial grimacing. The more complex motor tics include squatting, hopping, skipping, tapping, and retracing steps. Um, Vocal tics include various words or sounds such as the squeaks, grunts, barks, sniffs, snorts, coughs, and in rare instances, um, a complex vocal tic can involve the uttering of obscenities, which is probably what most people think of when they think of Tourette's. Vocal tics may include repeating certain words or phrases out of context, repeating one's own sounds or words, or repeating what others say. The movements and vocalizations are experienced as compulsive and irresistible, but they can be suppressed for varying lengths of time. Many report a buildup of tension as they attempt to suppress tics to the point that they feel that those tics must be expressed against their will. They're often worse during periods of stress or excitement and better during periods of calm. These disorders increase the risk of difficulty with reading, writing, and arithmetic. 86% of children with Tourette's disorder have at least one mental health, behavioral, or developmental condition. So again, we take our assessment data, implement that into the client database, and we are able to choose appropriate nursing diagnoses, and these would be some that would be appropriate for an individual or child that has Tourette's disorder. Again, looking at outcomes, setting goals, both short and long term. Again, timelines are individually determined, but these are some of the outcomes that we would want to see with this type of patient. So, goals for treatment of a child with Tourette's disorder should focus on keeping the client from harming him or herself or others, helping them interact with staff and peers, and helping increase self-worth. Interventions should include monitoring for self-destructive behavior, redirecting violent behavior with physical outlets, and providing group situations and setting limits on manipulative behavior. Evaluation. So again, we look at whether or not our interventions have been effective. Have they refrained from causing harm to self or others? Developed adaptive coping strategies? Been able to interact appropriately with others? Been able to suppress those tick behaviors when they choose to do so, and then set a time for release, so to speak, of those suppressed tick behaviors. They're able to verbalize positive aspects about themselves, particularly in relation to their ability to manage their illness, and have they complied with treatment in a non-defensive manner. Looking at pharmacological interventions, systematic review of current evidence supports the efficacy of antipsychotic agents, both typical and atypical agents, and the use of alpha 2 adrenergic agonist agents, such as clonidine, is used in treating tics. Pharmacotherapy is most effective when combined with psychosocial therapy, such as behavioral therapy, individual counseling, or psychotherapy or family therapy. Medications that are used for the treatment of Tourette's include your conventional antipsychotics like your haloperidol, your pimozide, and your aripiprazole, which is the Abilify. They've all been approved by the FDA for control of tics and vocal utterances associated with Tourette's disorders. They have been widely investigated and have been proved to be highly effective in alleviating the symptoms. They are often not the first line choice of therapy, however, because of their propensity for severe adverse effects. Haloperidol is not recommended for children younger than 3 years, and pimozide should not be administered in children younger than 12. Alpha agonists, clonidine and guanfacine, are the alpha adrenergic agonists that are approved for use as antihypertensive agents as well. The extended release forms have been approved by the FDA for the treatment of ADHD. These medications may be used for the treatment of Tourette's. Helpful when co-occurring conditions such as social language impairments, learning disabilities, or other communication disorders are present. Deep brain stimulation. So this is experimental and involves surgical implantation of electrodes to stimulate communication areas of the brain. Deep brain stimulation is an option when all other treatments have been tried and found to be ineffective. Moving on to oppositional defiant disorder. So this is characterized by a persistent pattern of angry mood and defiant behavior that occurs more frequently than is usually observed in individuals of comparable age and developmental level, and interferes with social, educational, occupational, or other important areas of functioning. The disorder typically begins by age 8 and usually no later than early adolescence. Prevalence estimates range from 2 to 16%, and common comorbid disorders include ADHD, anxiety, major depressive disorder, conduct disorder, and substance use disorders. Looking at predisposing factors, the role, if any, that genetics, temperament, or biochemical alterations have in the etiology of ODD is still unclear. Some studies have identified genetic influences in the establishment of a child's temperament, but there is no clear evidence of this connection. Opposition during various developmental stages is both normal and healthy. Children first exhibit oppositional behaviors at around 10 or 11 months, again as toddlers between 18 and 36 months, and finally during adolescence. Pathology is considered only when the developmental phase is prolonged or when there is overreaction in the child's environment to his or her behavior. Looking at assessment, initially the oppositional attitude is directed toward the parents, but in time other relationships, such as those with teachers or peers, also become affected. And these impairments in social interaction often lead to depression, anxiety, and additional problematic behavior. Usually, these children do not see themselves as being oppositional, but view the problem as arising from others whom they believe are making unreasonable demands on them. These children are often friendless, perceiving human relationships as negative and unsatisfactory. School performance is usually poor because of the refusal to participate and resistance to external demands. Looking at some nursing diagnoses, these would be appropriate nursing diagnoses for ODD. At what type of outcomes do we want to see? Again, setting short and long-term goals, understanding timelines again are individual, but these would be some things that we would want to see as um, outcomes for an individual with ODD. Intervention. So goals for treatment with a child with ODD should focus on completing tasks willingly, accepting responsibility for behaviors, demonstrating feelings of self-worth, and interacting with staff, peers, whoever appropriately. Intervention should include creating a structured plan of therapeutic activities, providing immediate positive feedback, ensuring goals are realistic, and explaining passive-aggressive behaviors. Evaluation. So again, are those interventions effective? Are they cooperating with the schedule of therapeutic activities? Is that level of participation adequate? Are they manifesting a less negative attitude toward therapy, accepting responsibility for problems and behaviors? Are they verbalizing the unacceptability of his or her passive aggressive behavior? Are they able to identify which behaviors are unacceptable and substitute more adaptive behaviors? Are they able to interact with others without defending behavior in an angry manner? Are they able to verbalize positive statements about themselves? Are they manifesting fewer manipulative behaviors? Are they able to make compromises with others when issues of control emerge? Are they able to express anger and hostility appropriately and verbalizing expressed ways of releasing anger adaptively? And are they able to verbalize true feelings instead of allowing them to emerge through the use of those passive aggressive behaviors? Looking at conduct disorder. So, with conduct disorder, there is a repetitive and persistent pattern of behavior in which the basic rights of others or major age appropriate societal norms or rules are violated. Physical aggression is common and peer relationships are disturbed. This is one of the most frequent reasons that children and adolescents are referred to psychiatric intervention. Prevalence estimates range from 2% to more than 10%. The prevalence rises from childhood to adolescence and is more common in males than females. There's a higher male predominance among those with child onset subtype. Several comorbidities are common with conduct disorder, including ADHD, mood disorders, learning disorders, and substance use disorders. Looking at biological influences, family, twin, and adoptive studies have revealed significantly higher number of individuals with CD among those who have family members with the disorder. Although genetic factors appear to be involved in the etiology of CD, little is really known about the actual mechanisms involved in genetic transmission. There's some evidence, though, of the distinction between behaviors that appear to be genetic versus environmental risk factors. The term temperament refers to personality to traits that become evident very early in life and may be present at birth. As early as age 2, children who show signs of an irritable temperament, poor compliance, inattentiveness, and impulsivity can begin to show signs of CD at later ages. Looking at neurobiological factors, Sadak and colleagues in 2015 identified three neurobiological findings relevant to relevant to conduct disorders. First one was neuroimaging studies identify decreased gray matter in the limbic structures, bilateral insula, and the left amygdala. Secondly, studies have found that high plasma concentration of serotonin and low levels in looking at psychosocial influences. Those peer relationships, family influences. So these factors related to family dynamics have been implicated as contributors in predisposition to conduct disorder and are typically in combination with one another to create a pattern of chaotic disruption in family life. We might see some of those influencing factors could be frequent changes in residence, economic stressors, a parent with antisocial personality disorder, alcohol dependence, and marital conflict and divorce. So assessment-wise, the classic characteristic of CD is the use of physical aggression in the violation of the rights of others. Behavioral pattern manifests itself in virtually all areas of the child's life: home, school, with their peers, and within the community. We might see stealing, lying, and truancy, which are common problems. The child also lacks feelings of guilt or remorse. Use of tobacco, liquor, non-prescribed drugs, as well as the participation in sexual activities occurs earlier than the expected age for the peer group. Projection is a common defense mechanism. Low self-esteem is manifested by kind of that tough guy image. Characteristics include poor frustration tolerance, irritability, and frequent temper outbursts. Symptoms of anxiety and depression are not uncommon. Level of academic achievement may be low in relation to age and IQ. These would be some appropriate nursing diagnoses for an individual with conduct disorder. At outcomes, what do we want to see happen? We set those short and long-term goals. And these would be the outcomes we would want to see with this type of individual. Plan and implementation. So goals for treatment of a child with CD should focus on keeping the client from harming others, helping the client interact with staff and peers, accepting responsibility for behaviors, and helping increase self-worth. Intervention should include monitoring for violent behavior, redirecting violent behavior with physical outlets, and developing a trusting relationship, providing group situations, and setting limits on manipulative behavior. When we look at evaluation, again, have our interventions been effective? They've been able to manage aggressive impulses. Have they been able to prevent harm to others or others' property? They've been able to express anger in an appropriate manner. Develop more adaptive coping strategies to deal with the anger and feelings of aggression. Have they demonstrated the ability to trust others and interact with staff and peers in an appropriate manner? Have they been able to accept responsibility for their own behavior? And is there less blaming of others? Have they been able to accept feedback from others without becoming defensive? Have they been able to verbalize positive statements about themselves? And have they been able to interact with others without engaging in manipulation? Question, conduct disorder may be a precursor to the diagnosis of which personality disorder? Go ahead and pause, think about it. Answers B. Antisocial personality disorder is a pattern of socially irresponsible, exploitative, and guiltless behavior that reflects a disregard for the rights of others. CD can be a precursor for the diagnosis of antisocial personality disorder. However, a diagnosis of antisocial personality disorder would not be assigned until a client is 18 years of age or older. Separation anxiety disorder. So looking at this one, separation anxiety disorder is characterized by excessive fear or anxiety concerning separation from those whom the individual is attached. The anxiety is beyond that which would be expected for the individual's developmental level and interferes with social, academic, and occupational or other areas of functioning. Onset may occur at any time before the age of 18, but most commonly it is diagnosed around the age of 5 or 6 when the child goes to school. Typically, the school teachers and counselors are the first to recognize anxiety and associated behavior disturbances. A high prevalence, about 43% of social anxiety disorder with onset after age 18, removed the diagnostic criteria that this disorder only occurs in children and adolescents. Prevalence estimates for the disorder average about 4%. Over 50% experience remission of symptoms within 10 years of onset, but there are several common comorbidities, including panic disorder, social anxiety disorder, specific phobias, depression, and bipolar disorders. Looking at some of those biological influences again, a greater number of children with relatives who manifest anxiety problems develop anxiety disorders than children with no such family pattern. The results are significant enough to speculate that there is a hereditary influence in the development of separation anxiety disorder, but the mode of genetic transmission has not been determined. Temperament, it is well established that children differ from birth or shortly thereafter on a number of temperamental characteristics. Environmental influences, stressful life events. Studies show a relationship between life events and the development of anxiety disorders. Children with mothers who were stressed during pregnancy also appear to be at greater risk for developing separation anxiety disorder. Family influences, various theories expound on the idea that anxiety disorders in children are related to attachment issues with the mother. Three family influences that have demonstrated an increased risk for anxiety disorders in children include parental overprotection, insecure parent child attachment, and maternal depression. Some parents may also transfer their fears and anxieties to their children through Assessment, occasionally the separation reluctance is directed toward the father, siblings, or significant individual to whom the child is attached. We might see tantrums, crying, screaming, complaints of physical problems, clinging behaviors. Up to 80% of children who with a school refusal meet criteria for separation anxiety disorder. Interpersonal peer relationships are usually not a problem with these children. They are generally well liked by their peers and are reasonably socially skilled. Younger children may follow the person they are afraid to be separated from. Interpersonal peer relationships are usually not a problem. They are generally, like I said, well liked, socially skilled. Um, worrying about Worrying relates to the possibility of harm to self or the attachment figure. Depressed mood is frequently present and often precedes the onset of anxiety symptoms, commonly following a major stressor. So again, we look at the data we collected in our assessment to choose appropriate nursing diagnoses, and these are some of those nursing diagnoses that you would see. Come again, setting short and long-term goals. What do we want to see? These are some of the things we would want to see as outcomes for this child. Planning implementation, again, setting those goals, interventions focus on establishing trust, assuring the client of their safety, exploring fears, helping the caregiver and child initiate realistic goals, and encouraging positive reinforcement for desired behaviors. Again, how effective are the interventions? They able to maintain anxiety at a manageable level. They had fewer complaints of physical symptoms, demonstrated ability to cope more adaptively. Are the parents able to have they identified more adaptive coping strategies as well? Have they verbalized an intention to return to school, been able to sleep without nightmares, or been able to interact with others away from that attachment figure? When we look at therapeutic approaches, we have behavioral therapy that's based on concepts of classical conditioning and operant conditioning and is common in effective treatment with disruptive behavior disorders such as ADHD, ODD, and CD. With this approach, rewards are given for appropriate behaviors and withheld when behaviors are disruptive or otherwise inappropriate. Family therapy for children and adolescents must involve the entire family if treatment is to be successful. Parents should be involved in designing and implementing the treatment plan for the child and should be involved in all aspects of the treatment process. Group therapy provides children and adolescents with the opportunity to interact within an association of their peers. They can be both gratifying and overwhelming depending on the child. Group therapy provides several benefits. Appropriate social behavior often is learned from the positive and negative feedback of peers. Group members learn to tolerate and accept differences in others, discover that it is acceptable to disagree, offer and receive support from others, and to practice these new skills in a safe environment. It is also a way to learn from the experiences of others. So might see the use of cognitive behavior therapy that has demonstrated a benefit in the treatment of tic disorders, such as Tourette's, separation anxiety disorder, disruptive behavior disorders, including ADHD, ODD, and CD. Looking at psychopharmacology, medication should not be the sole method of treatment. Although medication can improve quality of life for families of children and adolescents with these disorders, research has indicated that medication alone is not as effective as a combination of medication and psychosocial therapy. It is important for some families to understand that there is no way to just give them a pill and make them well. The importance of these psychosocial therapies in the treatment process cannot be overstressed.